The HANSE study is a multi-center study in northern Germany. And one of the key questions is the identification and determination of the high-risk group. So what is the high-risk group? And the HANSE study tries to answer that question. For example, traditionally, just pack years and duration of smoking are inclusion criteria, like the Nelson criteria from the Nelson study use that. And we sort of comparing that with a different definition of the high-risk group is the so-called PLCO score. Right? We didn't invent the score. It's out from Tamamegi for several years and has performed retrospectively quite well. And here we would like to examine it prospectively. And we chose a cut point of a 6-year risk of 1.56%. And we chose the cut point because then in Germany, through population-based calculations, the group from 55 to 79 has the same chance to be included via the Nelson risk inclusion criteria or the PLCO. Okay, and we did a power calculation, and for that we needed 5,000 high risk in the high risk group, and we accomplished that. We recruited all in total 5,191 participants. And the results we're presenting at the meeting are the baseline, first results from the baseline. So we detected a total of 64 cancers in these 5,191 high-risk participants. And it was really striking that we detected 62 out of the 64 cancers with a PLCO inclusion criteria, and only 49 cancers with a Nelson criteria. So in other words, the Nelson missed 15 cases, while the PLCO only missed 2 cases. And that said, we quite evenly distributed the 2 groups. It was 3,916 in the Nelson group and 4,167 in the PLCO group. So only 5% in between. So our calculations weren't that bad. And our primary endpoint was the positive predictive value for lung cancer detected in the PLCO selected versus the Nelson selected high-risk group. And no surprise with that numbers. We reached the primary endpoint. The positive predictive value for the Nelson selected group was 1.25%. And then in the PLCO selected group, it was 1.49%. So it's about 19% higher. And the difference between the positive predictive values using the Kosinski weighted method was 0.02. So that was significant. So taken together, we detected in the high-risk group with a PLCO criteria, so the cancer detection rate, 62 out of 64. This is nearly 97% of cancers, while we only detected 49 out of 64, 77% of cancers. And of course, we had a lot of participants who wanted to participate but did not meet either criteria. These were about 7,500, and through modeling, we sort of calculated the overall cancers we would have detected in the high and the low risk groups. And that was 80. So, and if you calculate the cancer detection rate out of 80, that's 77% with the PLCO detected and 61% with the Nelson detected. So you can say of the population who wanted to participate, over 3/4 you detect with a PLCO, and just shy of 2/3 you detect with the Nelson. And then we asked the question, what are the people, the populations, Nelson versus PLCO? And yes, and that's already previously known, PLCO are older and they have more comorbidities. But then we say, okay, we calculated the cumulative estimated life expectancies from the participants with detected lung cancers in the screening, right? And because we detected far more, right, with a PLCO, the estimated life expectancies were higher. Although they were older and had more comorbidities, they were 907 with a PLCO versus 756 years. And then we wanted to assess, because in America it's a big question, they acknowledge in America in the programs that the PLCO may be a better definition for the high risk cohort, but it's not feasible doing all the questions, because the PLCO is more than smoking and pack years. I withheld that. It's more sort of also ethnicity, education, previous cancer history, family cancer history, and presence of COPD, for example. And we found out that we had a online self-assessment, and we correlated this, or online or per mail self-assessment with the on-site physician assessment with a pneumologist. And there was a good correlation, 0.78, and no bias. And in the end, very few were only rejected because they didn't fulfill the criteria on premise. And then last but not least, we used an AI-driven algorithm with automatic detection, volumetry, and categorization of the lung nodules. We used a modified lung RAS classification where we added the volume doubling time right into it. And that led to a quite feasible positive predictive value for malignant versus benign biopsies or surgical resection of 61%. And I think this is a pretty good value follow-up round. So in conclusion, we say that the PLCO appears to be more reliable and more efficient than the Nelson criteria for selecting individuals to be enrolled in a lung cancer screening program. And they should be preferred for identifying the high-risk individuals based on the HANSE study. We plan further longitudinal evaluation